I'm Raisa Tender, and I'll be discussing cyanide poisoning, how to diagnose, and how to treat this evil poison. Remember, the most common cases are from fires to the firefighters, any person involved in the fire. Don't forget, they tried poisoning Rasputin by giving him cyanide. Cyanide could be gas, liquid, or solid. Cyanide poisoning could be inhalation, ingestion, skin absorption. What's causing the cyanide poisoning? These are smoke inhalation, smoke inhalation are the most common cases in the US. So next is suicidal ingestion. So pharmacists, doctors, nurses, medications such as sodium nitroprusides are the one at risks for this and the one that's causing it. And the third reason of cyanide poisoning is industrial exposure and polyurethane in the famous foam bubble wrap, which usually people eating or popping with their fingers. I myself do love to pop those bubble wraps. It's fun. Attention! Please know this by heart. Cyanide loves binding to ferric. Therefore, cyanide will either bind to ferric in the methemoglobin or will bind to ferric in the cytochrome C oxidase in mitochondria. Again, cyanide loves binding to ferric. Therefore, cyanide will either bind to ferric in the methemoglobin or will bind to ferric in the cytochrome C oxidase in mitochondria. In the absence of methemoglobin, cyanide have no choice but to bind with ferric in cytochrome C oxidase in mitochondria. Now, this enzyme is gone, irreversible binding will happen. This is enzyme inhibition. The complex 4 is now gone. Oxygen cannot access as an electron acceptor. Therefore, we will go to the anaerobic glycolysis as a source of energy. because ATP from the electron transport chain is no longer viable. So this pathway will no longer work when you don't have hemoglobin. But if you are relatively lucky and you have methemoglobin, it will bind cyanide with methemoglobin, forming cyanomethemoglobin by the liver rhodinase. Thanks to sodium thiosulfate, we will end with thiocyanate and eventually gets excreted to urine. Cyanide binds to ferric in the cytochrome oxidase. That leads to inhibition of complex 4, which is the cytochrome A3. Now there's no ADP formation, so when the mitochondria cannot utilize oxygen, it will shift to anaerobic glycolysis, which will lead to lactic acidosis. Then metabolic acidosis will happen. What type? High anion GAB metabolic acidosis. What's the normal GAB? It's 12. Here's the red blood cell, which contains the hemoglobin, and there's the tissue. Normally, your tissue is using lots of oxygen, which makes the concentration on the hemoglobin greater than the concentration of the tissue, oxygen in the tissue, which leads to diffusion. But now, your tissue is not using oxygen, so there's no concentration gradient for oxygen to flow from the hemoglobin to tissue. Oxygen gonna stay on hemoglobin from passing to the artery, then to the vein. Because there's no oxygen going in the tissue, because your mitochondria cannot utilize oxygen, which destroys the concentration gradient. There's no gradient, there's no flow in the tissue. The venous oxygen content is high as the artery. So, words of wisdom: in cyanide poisoning, despite the abundance of oxygen, it cannot be utilized by mitochondria. That's why it ends up to the vein. Eating lots of apricot almond is bad for you. Why? They contain amygdalin, which is hydrolyzed into hydrogen cyanide. One apple a day keeps the doctor away. Lots of almonds a day, mitochondria's gone astray. Eating lots of almonds will lead to cyanide poisoning. Patient's breath smells like bitter almond. How fascinating, right? So here is our nice firefighter who serves his community. I serve and protect, and I smell like almond. If your doctor can assess your ability to answer the question about cyanide poisoning, they will use the following scenario. Number 1, the firefighter is in coma and almond-like breath after a fire. Patient who was prescribed sodium nitroprusside and suddenly collapses. He has metabolic acidosis. A factory worker in a metal industry comes to ER comatose after an explosion in the mill. And a pharmacist who suffers from depression presents with confusion, seizure, and loss of consciousness. Clinically, we have symptoms and signs. What is the difference between symptoms and signs? Symptoms is what you as the patient complain of, and signs are what I, as a doctor or nurse, discovered or observed. Symptoms: weakness. Why? There's no ATP. The electron transport chain is gone. Tissue hypoxia. Yes, the tissue is not getting oxygen because the mitochondria is not utilizing oxygen. So oxygen is not going to flow from the hemoglobin to the tissue. Abdominal pain, chest pain, neurologic problems such as headache, vertigo, dizziness, seizures, and coma. All of them are the same with the carbon monoxide poisoning. Signs: dilated pupil diaphoresis, which is excessive sweating, because we don't say sweating like the normal public. We are sophisticated, so we say diaphoresis, which means sweating. Dysrhythmias, decrease HR, decrease BP, increase RR, cardiovascular wear, shortness of breath, and the important cherry red skin. Why? Because the partial pressure of the oxygen in the veins is high, and what gives your blood bright color, at least the arterial blood, is the oxyhemoglobin. When you have lots of oxyhemoglobin in your vein, the veins are now gonna look like the artery bright red. Your skin will look cherry red in color because your veins are more superficial than your artery. Don't waste your time on crap and let's go to the lab. Arterial blood gases, venous blood gases. How about the partial pressure of oxygen in the artery? Normal. Partial pressure of oxygen in the veins? Higher than normal because oxygen is not going into the tissues because we have destroyed the concentration gradient. PaO2 now roughly equals to PvO2, and the partial pressure is not the oxygen in the hemoglobin, it's the oxygen in the bloodstream. AV oxygen difference is decreased, it's less than 10%. What is AvO2 difference? It's the difference between the oxygen concentration in the veins and in the arteries. They are relatively equalizing. High anion gap metabolic acidosis due to lactic acidosis. And high anion gap metabolic acidosis is freaking acidosis, so the pH is low. What's the normal? It's 7.35 and 7.45. So it's below 7.35 if the pH is low. Decreased by carb, it's freaking metabolic acidosis. Increase in ion gap is greater than 12. What is an anion gap? It's positive on ions on one end and negative on the other end. And the difference between them is the anion gap. There is no actual ion gap. It's just measurement. Blood labs. We have increased blood lactate level is greater than 10. Increased plasma cyanide concentration. The EKG nonspecific sinus tachycardia is the best common or the most common ischemic changes. Carboxyhemoglobin concentration to rule out carbon monoxide poisoning and methemoglobin to monitor the therapy. Because we don't want to give patient too much methemoglobin because methemoglobin is also bad. It can cure poisoning, but it cannot go too far for it can kill you. You breathe in air. The air has oxygen. The percentage of oxygen as compared to the atmospheric air is called FiO2. Normally 21%. Oxygen goes to the lungs. In the alveoli, it's called P big AO2. Then goes to the arterial blood, it's called P small AO2. Jumps to hemoglobin is SaO2, jumps to the tissue. The tissue needs oxygen for electron transport chain and it produces carbon dioxide. Goes to the hemoglobin. This is called oxyhemoglobin. This is carbomin hemoglobin. There goes to the venous blood PvO2, partial venous pressure, then back to the lungs. You exhale carbon dioxide. What's the effect of the cyanide poisoning? In FiO2, it's perfectly normal. In P big O2, it's normal. PaO2, it's normal. SaO2, normal. How about the partial pressure oxygen in the veins? It's high. Now let's learn how to manage cyanide poisoning. First, remove the clothes. Why? Because cyanide poisoning can occur by absorption through skin. And don't waste your time unbuttoning each button only because the shirt was expensive. Just get them off. Don't be an SSS like the super sophisticated then wash body with soap and water. Do not wait for the labs. If you suspect cyanide, treat it. How to treat? 100% oxygen, then the hyperbaric chamber. Remember, ABCs first. Airway, breathing, circulation. Established an IV line and G. Monitoring continuously. Give cyanide antidote. What are the antidotes? The famous triad: hydroxycobalamin, sodium nitrite, and sodium thiosulfate. Let's talk about sodium thiosulfate. Sodium thiosulfate helps the cyanomethemoglobin goes to the thiocyanate, then becomes excreted to urine. Sodium nitrate, it converts the normal hemoglobin into the methemoglobin, so the methemoglobin can combine to cyanide forming cyanomethemoglobin, then excreted into the urine. So here's the famous triad: hydroxycobalamin, sodium thiosulfate, and sodium nitrite. Sodium nitrite converts the hemoglobin into methemoglobin, the ferrous into ferric, then the methemoglobin will bind to cyanide forming the cyanomethemoglobin, liver rhodinase, sodium thiosulfate, then thiosulfate excreted into the urine. Then hydroxycobalamin binds to cyanide, becomes cyanocobalamin, then excreted into the urine. So that ends my presentation. Thank you very much and be safe, everyone. Thank you.